Hello there, I'm Jim Watchorn. I'm a senior trainee in intensive care medicine and renal medicine, and I've been asked today to talk to you about acute kidney injury and renal replacement therapy. So we're just going to look at the beginning at AKI. As you know, since 2013, the RIFLE criteria, the AKIN criteria have been done away with, and a global network of doctors and nephrologists and intensivists got together and came up with kidney disease improving global outcomes, AKI staging criteria. There are 3 stages. Stage 3 is the worst. It's based on your serum creatinine, or it's based on your urine output. And the problem with the staging system, if you want my opinion on it, is that creatinine is an imperfect marker. It's got really nothing to do with the kidney. Creatinine is made by muscle breakdown, and it's just filtered by the glomeruli. And it doesn't really indicate acute kidney injury. It indicates renal loss of function, which are not quite the same thing. And urine output is more sensitive, but it lacks specificity. So for example, you could have a low urine output because you're dry, but you don't have an AKI. You could have a high urine output because you're polyuric, but it really doesn't really reflect anything that's going on in your kidney. The other thing about urine output is it takes a period of time for you to measure it in order to diagnose someone as having AKI. So if you look at the staging criteria, you need to have anuria for 12 hours. What else have we got in there? 6 to 12 hours, 12 hours, more than 24 hours. So you need a considerable period of time in order to diagnose acute kidney injury. Looking at the graphs on the right, we'll take the bottom right one to begin with. Unfortunately, creatinine doesn't have a linear relationship with GFR. So this is the relationship between serum creatinine and GFR, and as you can see, it's exponential. So if, say, for example, you had a baseline creatinine of 100 and you increased it by 200, so you went from 100 to 300, which you can see on the scale on the right, and that's increment A. You've actually dropped your GFR from 70, which it was at 100, down to less than 20 by increasing your creatinine 200 points. So a massive drop in your GFR, 70 to 20, 50% loss of your GFR at that point. Okay, now let's look at line B. So different patient whose creatinine was 500 and now it's gone up to 700, so the creatinine has risen again by 200 points, but actually their GFRs dropped from, let's say, 12 to about 8. So a much smaller shift in GFR for the same change in creatinine. So therefore we have to come up with estimated GFR calculators which help us know what the GFR is based on the creatinine. The other thing to say about creatinine, as you look at the graph in the top right, is that it is not a marker of injury. As I've said, it's a marker that's a loss of function, and it just accumulates. So if I was to say take both your kidneys out right now, your creatinine probably wouldn't peak for about 3 to 4 days because it has to accumulate in the blood. So you can have a very severe acute kidney injury, but you're detecting it too early and your creatinine's not really risen as a result. So what are the long-term consequences of acute kidney injury? Why do we care? Can't we just filter people, and when their kidneys are better, then we can stop filtering them and they can just carry on their merry way? Well, if you have an AKI that lasts more than about 72 hours, it's an independent predictor of mortality at 6 and 12 months. It increases your in-hospital mortality, which is independently shown separate to your severity of illness. It increases, if you have an AKI episode which lasts for more than 3 days, it increases your risk of hypertension, stroke and major cardiac events in the long-term future. And you end up with this irreversible loss of kidneys as a result of your irreversible loss of nephrons as a result of the AKI, which results in fibrosis and scarring, and then this eventual cardiovascular poor outcomes as a result. What can you see there? So there's 2 slides there. No talk's really complete without some renal biopsy specimens. So we're just going to zoom in now on the slide, and what you can see here are 2 renal biopsies of the tubules. There's a glomerulus with the laser pointer, you can see this up here, and this top one is severe acute tubular necrosis or severe acute tubular injury. This is the glomerulus, which is the big blob in the top left, but what I want to bring your eye to are these tubules, which are these white spaces here that have been crossed through so they look like donuts or elongated donuts. And you can see how thin the walls are here, and that's because the cells have hibernated, they've lost their mitochondria and they've stopped working properly. If you compare it to a normal biopsy, which is below, you can see the tubules here have much thicker walls, they're much more chunky. And eventually, if this injury is severe enough in the top slide, you end up with fibrosis as a result, and it's irreparable. So what are the causes of AKI? Because AKI is a syndrome, it's not a disease. And there are loads of causes which you have, I'm sure you've all come across this sort of classification before, what we used to call pre-renal, renal and post-renal, or perfusion related to both the arterial supply to the kidney or the venous return from it within the kidney, so intrinsic renal disease such as glomerulonephritis, or obstruction of the kidney, so anywhere from the collecting ducts down. So in my book that also includes things like rhabdomyolysis, where you get deposition and crystallization of myoglobin within the tubules, down to those problems which are best managed by a urologist. But yeah, that's really how you break down the causes of acute kidney injury. The predominant in-hospital cause, other than sepsis, is what we call acute tubular necrosis or acute tubular injury, because the tubules aren't actually necrosed, so it's a bit of a misnomer. And what occurs here is that you have lost those pumps that you have in the thick ascending limb of your loop of Henle. So if you've watched the renal physiology lecture, we talked in some depth about how your loop of Henle works to generate concentrating gradients. But those cells with the pumps that drive the concentration gradient, of which everything else is selectively transported against, have lost their ability to generate a concentration gradient. Those sodium potassium ATPase pumps have, or those cells are hibernating and no longer working. And therefore you lose that concentrating gradient, and why some patients with ATI, ATN will have a polyuric phase, which you may have come across. This is particularly, well, this occurs really because that thick ascending limb is really at risk of a hypoxic injury because they're very metabolically active, driving out all that sodium, but their oxygen delivery is further down the pathway. So the blood has already arrived at the glomerulus, it's already gone down into that relatively hypoxic environment that is in the sort of deeper medulla, and then it's trying to offload oxygen after that. So they live in a relatively hypoxic environment and they have a high metabolic demand. So if you do anything to screw with that, the cells are not going to like you and they're going to shut down as a result. So really that's AKI in a nutshell. What do you need to worry about? Because you're not going to fly out to someone who's got stage 2 AKI, you're just going to bring them, they're just going to come home some other way. But who do you need to deliver renal replacement therapy to, which is the ones that I mostly really care about? There are 3 hard indications of which these patients need renal replacement therapy, and they're the ones that you need to activate a team to go out and retrieve. And those 3 indications are intractable hyperkalemia. And particularly this occurs in anuric patients, because in patients that are peeing, you can just encourage them to pee out more potassium via a number of different medical methods. But in your patients that are anuric or oliguric and hyperkalemic, you have to get the potassium out of the body because it's cardiotoxic, and you have no other way, if they've stopped peeing, than to remove it by an extracorporeal circuit. The other 2 are severe fluid overload that's causing pulmonary edema in a patient that's anuric. You could argue that you could put these patients and positively give them positive pressure ventilation before you retrieve them. Maybe that will buy you some time, but you actually have to remove the fluid from the body somehow, and if they're anuric, then renal replacement therapy is indicated. And in severe acidosis, again, another hard indication for renal replacement therapy. Creatinine is not an indication for renal replacement therapy, it just gives you an indication of what their GFR is. So if you don't have renal replacement, what can you do for those hard indications? Well, you all know the treatment of hyperkalemia. You stabilise the myocardium with some calcium. You can drive the potassium from that sort of plasma space to the intracellular space by giving them insulin dextrose or giving them beta agonists. Bicarb does the same thing, and actually bicarb helps you release potassium into your urine, so if they're still peeing, you can do that. And frusemide also encourages what we call a caliuresis, that urinary loss of potassium. So frusemide can drive potassium loss in the urine, and you can use that to your advantage by giving high-dose frusemide to hyperkalemic patients, provided they're still peeing. Try and drive down that plasma potassium. You may end up with someone that becomes slightly hypovolemic, so this is not a bad situation where you might give frusemide and fluids. It's not totally daft. You're driving out potassium-rich urine and replacing it with a potassium deplete fluid. To stabilise a severe acidosis, you can give intravenous bicarb, particularly if it's an acute kidney injury. It's a good indication for intravenous bicarb. And for volume overload, as we've touched on, you've got positive pressure ventilation, or potentially you've got a role of different venodilators. So there we've really summarised acute kidney injury, what the main causes are, why they occur, how you can manage those things medically, and what the key indications for renal replacement therapy are. And now we're going to move on to look at renal replacement therapy.